It now gives me great pleasure to make the introduction for our keynote speaker, Celia Fisher. Celia Fisher is the Maria Ward Dowdy University Chair in Ethics, Professor of Psychology, and founding director of the Fordham University Center for Ethics Education. She is also the director of the NIDA-funded HIV and Drug Abuse Prevention Research Ethics Training Institute, now beginning its 6th year, she currently chairs the Ethics Codes Revision Task Force for the American Public Health Association, and has served as chair of the American Psychological Association Ethics Code Task Force. Dr. Fisher has also served on the Environmental Protection Agency's Human Subjects Review Board. She served on SACARP and several other national committees on human research protections. Dr. Fisher is a well-known author of over 200 publications and federally funded, and has been awarded numerous federally funded research programs focused on creating an empirical basis for ethical decision-making in research involving vulnerable populations. This includes work with ethnic minorities, youth and families, active drug users, the LGBT community, and adults with impaired consent capacity. Dr. Fisher was awarded the Lifetime Achievement Award for excellence in human research protections in 2010, and named a 2012 Fellow of the American Association for the Advancement of Science. Really, really heady qualifications. Huh? So it is my great pleasure to introduce you now to Celia B. Fisher. Dr. Fisher. I'll try to do better than I did for my own.
Okay. Yeah.
Okay.
Oh. You're an expert.
It takes practice, right?
Okay. Thank you very much. Can you hear me? Yes? Okay. So today the vulnerable populations that I'm going to speak on are vulnerable adolescents in health research. And I'm first going to talk about 3 different tensions that we face that create ethics dilemmas in this kind of research. First of all, we want to have human subjects protections that respect youth's developing autonomy, but at the same time protect them from research harms and that might arise from their age vulnerabilities. We want to avoid overprotective policies that may deprive youth of participation in research that's essential to improving age-appropriate health behaviors. And at the same time, we want to critically evaluate whether there are implicit systemic biases that are placing an undue burden on socially marginalized youth. So one way that I've approached this problem is to clarify the definitional problem of vulnerability. Now, many of you are aware that 46.111 has 2 requirements for IRBs to consider when there are vulnerable populations, and that is they need to consider additional safeguards to ensure selections of subjects is equitable and not subject to coercion. And the regulations give children as a specific example, and I think that causes a lot of consternation among IRBs, because what we don't have is guidance on what kinds of safeguards are actually required for children above and beyond those already stipulated in Subpart D, which is additional protections. And it's also difficult to know the extent to which these vulnerabilities persist from childhood into adolescence. So one approach that's very important to take when developing protections is that we should not consider that adolescence in and of itself equals research vulnerability. Failure to distinguish between the vulnerabilities in an adolescent's everyday life and research vulnerabilities can lead to an under or overestimation of research risks. So for several years, I've been working on a model of decision-making called goodness of fit ethics. And there are a number of assumptions relevant to adolescent research that are associated with this model. First, the burden of identifying research vulnerability should not simply lie in the fact that a subject is an adolescent. Second, failure to recognize youth strengths can be as harmful as failure to recognize their frailties. And so research vulnerability occurs when human subjects' protections are not fitted to either the youth's developmental strengths as well as their needs. And so IRBs and PIs need empirical data to help them identify what are these ethically relevant youth strengths and weaknesses. So one form of empirical research that I've been conducting for many years is the importance of participant perspectives. The science establishment, when we're trying to come up with good ethical procedures, relies on ethical principles like the Belmont Report, our federal regulations, IRB and PI experience, and the traditional ethical protections that we've put into place. However, participants have a very different lens through which they look at research ethics. They have their own moral values that may or may not be in sync with the Belmont principles. They can tell us about how trust or mistrust in the scientific enterprise is going to influence how they respond to research procedures. They know whether or not the protections that we put in place can actually be implemented in the real world, and how the ethical decisions will affect their rights and welfare. So a goodness of fit model recommends that participants are looked at as experts who have very different expertise to contribute to human subjects' protections. So today I'm going to give you an example of 3 types of research I've conducted to try to gain participant perspectives on these issues. The first will be an HIV PrEP adherence trial involving LGBT youth, and here I want to address issues related to when there should be a waiver of guardian permission. The second case will be pediatric cancer trials, and here I'll be talking about when you have to waive adolescent assent. And then finally, I'm going to talk about genomic research on violent behaviors involving ethnic minority youth, and here we'll talk about avoiding bias and social harms. So this is a frame from an animated video that we presented in a study to adolescents looking at issues related to guardian waiver for HIV prevention research involving LGBT youth, which I'll talk about in a minute. First, I want to give some background. The CDC recommends that pre-exposure prophylactics, called PrEP, which is now taken in pill form, for high-risk populations to prevent HIV infection. Epidemiological data has identified young men who have sex with men, bisexual women, and transgender youth between the ages of 13 and 24 as comprising the majority of new HIV diagnoses in this country. Yet, there are currently no evidence-based HIV prevention programs for LGBT youth. One reason has to do with perceived youth vulnerability. In some instances, IRBs sensitive to this vulnerability has required guardian permission, which in turn has ended up with low recruitment for LGBT youth. And in fact, some studies like the ATN studies in some states has had to curtail any research in this area because of lack of recruitment. Now, why is this an issue? Well, without youth involvement in research, we don't have any evidence-based practices, and either PrEP will continue to be unavailable to certain LGBT youth, or it's going to continue to be prescribed off-label. So 2 research questions that can help inform IRBs about this decision is, when is guardian waiver ethically justified, and is adolescent self-consent an adequate protection? So let's look at the regulations. First, we have to ask whether or not are LGBT youth in an HIV prevention study actually children under federal regulations. Well, if you look at the definitions under Subpart D of what a child is, minors are classified as adults if they have attained their state-defined legal age for consent to treatment or procedures involved in a research study. Now, most states have mature minor laws that permit youth independent access to HIV testing, and some states allow for treatment. So in those states, youth actually can be considered adults under the OHRP and federal regulations. However, we're really very confused about mature minor laws. Some IRBs may not be aware of the definition or may not refer to it. Other IRBs may know that the child may qualify as an adult but are worried about adolescence as a vulnerability and so want to add the guardian permission requirements. And some IRBs have institutional attorneys who are very risk averse and say because most state laws are silent with the term research, we don't want you to waive any guardian permission. So we're not going to solve that problem today, but I just wanted to alert you to it. However, even if youth are considered children, we can still waive guardian permission under Subpart D. For minimal risk research, 408 refers us to 116, which says that if it's minimal risk research and research could not be practically carried out, then all or certain elements of informed consent can be waived as long as appropriate protections are in place. And when there's greater than minimal risk research under Subpart D, guardian permission can be waived when it is not a reasonable requirement to protect the subjects. Now here, the federal regulations gives the example of neglected or abused children, and this raises another definitional problem, because many times IRBs are reluctant to go beyond examples that are given in federal regulations, and so research can help inform what are equivalent to neglect and abuse in terms of not a reasonable protection for children. So the study I'm going to talk about is funded by NIMHD. The PI is myself and my colleague Brian Mustansky. We're now moving into our second year, and I'm reporting on the first phase of our study conducted in the first year. We recruited 74 sexually active 14 to 17-year-old LGBT youth. They viewed an animated description of a PrEP HIV prevention study that is actually being run with young adults. Now, what I want to point out is that we crafted this animated video to be sensitive to the educational needs of youth. Whenever you're doing research or asking your PIs to pilot certain ethical procedures, it's very important to educate participants as to what you're talking about. You can't ask them for an ethical decision if they don't understand what the research is about. So that's very important. And so after we presented the video, we presented web-based survey questions and asynchronous focus group discussions. For those who don't know what they are, they're like chat rooms where the researcher asks a question, the youth type in responses to the researcher and to one another. It's a wonderful approach. So what was the study that we were asking them to comment on? First of all, we gave them HIV basics, how HIV is transmitted, what it's like to get an HIV test. We told them how PrEP works for those that are not familiar. PrEP does not protect against STIs, so it's recommended that youth and others still use condoms. The side effects are quite minor. It's nausea, diarrhea, and some rare bone weakness, which is also minor and can be corrected as soon as someone's off of PrEP. And the pill must be taken daily to work. And so one of the problems has been, how do you get youth and young adults to actually adhere to a once-a-day pill? So studies that have been designed test whether or not text messaging can help improve adherence to PrEP for LGBT youth. We explained what random assignment was, that half of the participants would get the text messages, half wouldn't, and the inclusion requirements, that the youth had to be HIV negative, at risk for sexual behavior, which means that they're engaged frequently in sex with multiple partners, not using safer sex protections, and that the study is a year long and requires returning to the study site every 3 months for HIV testing and counseling. So the first question we asked was, would you participate in a PrEP study if guardian permission is required? And what do you think they said? I bet you think they said this. But we're only partially right. 61% of the youth who were not out about their sexual orientation to parents would refuse to participate, and 21% of youth who were out would refuse. Now, those who said many of them said maybe. So these percentages don't indicate that the rest said yes. So we asked them, what are the reasons for and against guardian permission? The reasons for guardian permission for many of them was if their parents were supportive of their sexual orientation. Others talked about how their parents could help them take care of their health, remind them about the pills, that the parents would help make sure the consent was informed and voluntary, and that it would help them convince their parents to let them be in the study. The reasons against guardian permission really focused around how supportive parents were or whether or not they knew of the youth's sexual orientation, and there were many concerns about punishment, stigma, and that would occur if in fact their parents learned or even were reminded about their sexual activity and sexual orientation. And unfortunately, social behavioral research indicates that this is a real problem for sexual minority youth, that they are punished, they are kicked out of the house in too many instances. Another issue that IRBs have to consider if guardian permission is waived is that through the course of the 1 year, some youth may seroconvert to being HIV positive. And so we asked them, would you want the researcher to help you tell your parents if you were HIV positive? 34% said no. Once again, they were concerned about coming out homeless or negative attitudes. My mom would call me a stupid whore. Others said, look, I would tell them, but I would need your advice on how to do it. The youth that said they would want that help felt that they didn't have the expertise. They really wanted a researcher to help explain it to their parents and to lessen the blow. So, what does this type of research tell us? It does tell us that LGBT youth are at the highest risk of getting HIV, but lack parental support, will not participate in a PrEP study if guardian permission was required, and that many fear punishment or family rejection if their LGBT status was revealed through guardian permission requirements. So from this research, for these youths, guardian permission is neither practicable nor a reasonable protection, and that satisfies the federal regulatory requirements for waiver of guardian permission. Now, some of you may say, well, 50% of kids might agree, but the problem is if the kids most at risk, who are most stigmatized or afraid of their parents, are not the ones that are participating, then we don't know whether or not the prevention measure that we tested is adequately generalizable to that population. So it's really a question of scientific validity. So what are some goodness of fit recommendations for thinking about guardian waiver from this type of research? First, IRB should consider whether adolescents recruited for HIV prevention research are actually children under Subpart D. And if they are children, is there evidence, like I just presented, indicating that guardian permission is neither practicable or perhaps not a reasonable protection? But when guardian permission is waived, youth should be given the option of including parents in the participation decision, because you saw that some youth want to. Parents can offer good protections, and we don't want to communicate to youth that we don't respect parental advice. When we are waiving, we should also have a participant advocate who can provide some of the protections that parents provide. And as one youth told us, a participant advocate can give us an unbiased opinion. And investigators should be required to develop procedures for youth who test HIV positive, and these procedures need to be sensitive to the risk of outing and provide support for sharing diagnosis with parents or referring youth to age and LGBT-appropriate HIV services. So the second empirical question related to this issue is, if we're going to waive guardian permission, can youth make a reasoned participation decision? So what we did was we asked youth about the critical elements of making a reasoned decision and asked them how they would make a choice about whether or not to participate. When it came to random assignment, youth thought that, I feel like being randomly put into groups is the fairest way to decide who gets a reminder and who doesn't. Some thought that allowing us to choose our own group would in some way make the information irrelevant. Others who were very negative about random assignment nonetheless understood what it was. They felt they would feel like a guinea pig, or they felt that no matter what, researchers should be doing what's best for them. Now, what I want you to do as you look at these kinds of quotes is the important thing here is to consider, are these adult-like quotes? Are these what we would expect of an adult in terms of making an informed consent decision to this kind of research? And we're always faced with this irony that youth are considered adults at 18, but not at 17. And so the issue really is, are these the kind of informed decisions that 18 to 24-year-olds would make? We asked them about research benefits, how they would take that into account. The youth said it's good to know my HIV status. Something that came out that was very important, I think, is that 60% of youth said they would be more likely to want to get tested in a research study than with their regular physician. And the reason for this, which we're publishing in another study, is how poorly their pediatricians understand LGBT sexual behaviors, or stigmatize it, or only talk about abstinence so they don't get any access to HIV testing or education. Others thought that having protection against HIV on a daily basis was a benefit, and that it would help focus them on the possibility of getting HIV and in turn make me practice better sex. I was hoping they thought safer sex, but if we're doing that, that's great too. So, and then many of them talked about how important they thought their participation was for other youth nationwide like themselves. What about side effects? And remember, keep in mind, are these the kind of decision-making that we think would reflect adult decisions? It's important to take into account risks when starting any medication. I would consider participating in terms of whether I could tolerate side effects. A number of them were concerned about the effect on their bones, especially those kids who had other conditions that were already being treated, and then those kids said they wouldn't participate because of the possible effect on bones. Others, like you can see, this young person said that they were pretty confident that the checkups every 3 months would help identify if that risk emerged. And as one youth said, risks are nothing compared to living with HIV. What about privacy risks? Some youth were very concerned that being in the study would out them if somebody saw them text messaging or taking pills, but most of the youth could care less about privacy and text messages because they're so sophisticated. They told us all these different ways that they protect their texts from people who don't know about their sexual orientation, and I thought this was a great line. If I was that worried about privacy, I wouldn't be part of that kind of study. What about an appreciation of personal HIV risk? Because remember, you have to engage in high-frequency, high-risk sex in order to receive PrEP. They were very much thinking about their own personal consequences. I would think about where it would fit in my lifestyle and if I needed it. I think about how sexually active I've been recently and the likelihood of my becoming active. And many of them thought about the risks and benefits for both themselves and their sexual partners. They also considered adherence challenges in terms of whether or not they'd want to participate. Those who took pills all the time thought that taking another pill really wasn't going to be a problem for them. Others talked about how forgetful they were. When they were on birth control pills, they forgot to take it, and so they wouldn't want to be in such a study because they didn't think taking PrEP would be helpful to them. So, what does this tell us? For the most part, when youth receive an educative information that allows them to have consent preparedness, they can, for the most part, make a reasoned consent decision about this type of research. And so from an IRB perspective, if guardian permission is waived, investigators should ensure that consent is fitted to the informational, health, and social needs of the participants. In addition, our focus group participants made recommendations on how informed consent could be enhanced. They wanted fact sheets. They said it was really important to have a respectful and caring person delivering the information who would welcome questions, who would give them time to decide. They were very positive about a youth advocate, and I loved what this youth said: I would like to see past results improve for why you're doing this study. Now, given the insurance and financial limitations, we also asked youth, would you want to be in this study if you knew that the researcher could not provide you with PrEP when the study was over? Many of them said they would think about that, but they did not think it was the researcher's obligation to continue to give PrEP, but that the researcher did have two obligations. One was to provide them with referrals for where they could get PrEP, and number two, to make sure during informed consent they were told that it might be difficult to get PrEP if it was when the study was over. Okay, so that's my PrEP talk. Now I'm going to go to almost the opposite side of the coin, and that is, when should assent be required in pediatric cancer trials involving adolescents? Regulations allow for great flexibility for IRBs in terms of whether or not assent is required. If the child's capability is so limited that they can't reasonably be consulted, or if the intervention or procedure involved in the research holds out a prospect of direct benefit available only in the context of the research. So here's a little background on pediatric cancer research. It's probably been the most successful pediatric research that we've ever had. Over the last 30 to 40 years, cancer survival has increased dramatically, and still 70 to 90% of adolescent and child patients are enrolled in some type of pediatric clinical trial when they're being treated. However, it's a very stressful time for parents and for youth. Consent is often required when the family first learns about the teen's diagnosis, or the patient has been unresponsive to current treatments, and therefore the experimental add-on may be something that's useful, or the adolescent is in pain or cognitively impaired by the disease or current medications. So this presents some adolescent assent dilemmas. Patient involvement in consent decision can certainly have the possibility of increasing self-worth, a sense of autonomy, and ability to cope with illness anxieties. However, serious health problems and current treatment side effects may impair teens' cognitive and emotional consent abilities, or informed consent may negatively affect their health outlook and confidence in practitioners. And finally, we have to consider how is a researcher going to deal with conflicts in the decision to participate between parents and youth. So with Jessica Masti, who was a student at that time, we conducted a small study with 23 adolescent cancer patients, 11 to 23 years, and 15 parents of patients, all of whom have participated in cancer trials, and they were in continued treatment or checkups at the medical center where the trials had been conducted. And so what we did was we gave them a questionnaire, and then this was followed by group discussion. So a majority of patients and parents, when asked about what factors a researcher should use to determine if adolescents should assent, they agreed that the researcher needs to consider the patient's age and consent maturity, the current health of the adolescent, were they weak, were they in pain, their prior research experience, whether or not, how knowledgeable they were about their current diagnosis, how the patient would react to learning that the experimental treatment may not work, and how patients usually feel about making treatment decisions. We asked them what a patient should be told about the research during a consent conference. The majority of patients and parents thought the adolescent should be told they were recruited because they had cancer. They should be told about both the mild and serious risks of some of the medical procedures, damage to healthy organs, interference with schoolwork, nausea, the type of medical procedures they would undergo, and how they, the pain or lack thereof that might be associated with that, and other treatment options. However, parents, somewhat more than patients, were wary about telling children certain things. First of all, being recruited because other treatments are not effective, telling the youth that the doctor does not know whether the treatment will work, and random assignment. And notice here that around 30% of youth were also concerned about these issues, and the reason was that both the youth and parents thought that for some patients it would make them feel hopeless or not have trust in the medical establishment, and therefore might interfere with recuperation and recovery. But the majority of both parents and participants also believe that involvement in informed consent can give patients a sense of control over their lives, but that parents had a responsibility to shield children from feelings of self-blame or guilt if participation did not produce results. And parents, more than patients, although around 50% of patients believed that parents have an obligation to shield children from research information that might cause emotional distress, and that it is the parent's responsibility to make serious health decisions for children. So, should patient assent always be sought in these types of studies? Sometimes when a waiver of assent is being sought, IRBs can make a broad-based decision. They can decide that it should be waived for all youth. But in this situation, as you can see, there's so much medical variability. There's so much variability in the attitudes of the patients and the parents themselves that I think these decisions have to be individualized to the patient. So the question is, what kind of guidance can an IRB give researchers in terms of determining the extent to which an adolescent should be involved in agreeing to participation in a pediatric cancer trial? So first, the researchers should consider the child characteristics, the child's maturity, the current health, their emotional readiness to understand disease, and to understand the unknown effectiveness of the experimental treatment. The researchers should consider the extent to which a joint consent or waiving assent would preserve family cohesion. For example, what is the history of medical decision-making? How does culture influence child and parent preferences for who makes the decision? And what are the consequences of potential decisional conflict? How is the researcher going to help that family resolve if the child and the parent don't agree about the participation decision? Which decision is going to rule? And that brings us to the severity of the disease and the potential research benefits. We need to know whether or not the patient has been responsive to available treatments and whether or not research presents benefits that are not available outside of the research. And finally, one should never ask a teen for assent if the dissent will not be determinative. That doesn't mean that you don't provide information to teens and ask them for their feedback, but you do so to obtain appropriate information that will help best fit your procedures to the patient's informational, emotional, and treatment needs. Okay, so we're all over the place today, but I hope this looks somewhat cohesive to you. We are now going to talk about genomic research on risk behaviors involving ethnic minority youth. Genetic testing is increasingly being used to study the correlates of behavioral problems in children and adolescents and whether or not their genetic profile makes them more or less responsive to intervention programs. In terms of violence prevention programs and looking at aggressive behaviors or conduct disorders, these gene intervention studies have largely been focused on African American minority youth. Some of you may remember in the 90s the NIMH Violence Initiative. This was an initiative that asked researchers to apply for grant funding to study inner city youth who had a genetic predisposition to violence. At the time, that genetic predisposition was defined as an older sibling with a criminal record. And these youths would receive biomedical psychiatric intervention to prevent future delinquency. Well, you can imagine there was a big uproar about that decision because although the initiative did not say African American youth, because it was going to be in their cities, it was largely going to be focused on those youth, and the American Black Psychologists organizations and others complained, and the studies were not implemented. Now we are still doing that kind of research, but we've gotten much more sophisticated. So now that genomics is rising and at such a rapid pace, we have studies like the Family School Partnership that recruited youth who had a genetic predisposition to aggressive behavior defined by a particular genomic cluster. They received an early childhood school-based intervention to reduce aggressive behavior in early adolescence. Now, what's important here was that when you read the abstract and the title, you don't know that it's African American youth that were studied. You have to go into the participants section. And when I've reviewed this for a paper that I was writing, it ends up that it is largely African American populations or poor populations that are being tested for whether or not these interventions work. So the kind of larger moral issue that I think frames this question, I think it comes out of the Nuremberg Code Principle 2. That is, to be of benefit, an experiment should be such as to yield fruitful results for the good of society. But who determines what's fruitful, and who determines what the good is for society? Now, when it comes to social behavioral research and the influence of genes, we're all over the place. Unlike certain medical disorders where there may be one gene or two genes that you know predict a particular medical disorder, that is totally untrue in any type of behavior, including intelligence. Genetic factors associated with impulsivity, aggression, and violence. We have found that there are multiple genes that act in combination to produce that are associated, they don't produce, but are associated with any of these behaviors. Hundreds of different genes may independently influence the same behavior. So just because you have one gene doesn't mean you're going to have that behavior, and if you don't have the gene, you may have the behavior anyway. Genetic effects, even when there are significant results, account for only a small proportion of individual differences in social behavioral research. The majority of the variability is environmental. And even if a gene intervention study proves significant, the effects are probabilistic. They lack individual utility. We never know if an individual child with a particular genetic profile is going to have a behavior. So I love this cartoon. I'd pause for a moment so you can let this information sink in and you can see how confusing it is. Okay, so in genomic adolescent violence research, for whose benefit and who decides, with my colleague, Seattle Wallace, who was my student at the time, we did an NSF-funded study involving 100 racially and economically diverse teens and parents. We showed them video clips of adolescent risk research. Remember, if you want to know the opinions of participants about ethical issues, you've got to explain what the research actually is. Then they were involved in focus groups talking about not only studies looking at genetic influences on violence behavior, but also on drug use and other high-risk behaviors. So one of the themes that came out was a concern about social political bias. As one adolescent said, they do research in the schools about white students who do good, but about crimes, they only talk about black people. Others said, one of the fathers said, they know the reason why. There's violence, ghettos, racism, and prejudice may still exist, but they don't want to say that. They want to say it's in their genes to make a cover story. And although this is about drug use, I was very taken when one of the parents said to me, you know, Dr. Fisher, we are sick and tired of you researchers coming in and studying drug use in our communities, because until you study why the government is allowing the drugs to come in, nothing's going to work. Another theme was scientific validity and implicit race-based inferences. For example, a number of kids pointed this out. I think it might be possible for it to be biological, but it's not one race. Look at white Hitler and South Africa apartheid. Why don't they study white suburban serial killers or the KKK? And I thought this was an excellent way of putting the futility of looking at any actually race-based genetics. One girl said, my moms and pops spoil me and I'll still be a bitch. I will still fight. Why? Because it's already in me. I guess it probably is genetic, but hey, I'm Puerto Rican, Black Dominican, Italian, and Cuban. You pick a race where it came from. some of them pointed out, one of the things that was a little depressing to me, but also, you really have to learn from these experiences. A lot of them thought researchers were simply entrepreneurs in the research establishment, and that what their goal was to get money and produce research that was continue to get them money. And so, as one of the parents said, scientists are always trying to make generalizations. They want to make a statement like X% of this and Y% of that, but the next week they'll get completely different results. So what about social values and social harms for whom's benefit? Many were worried that this would promote racism. It promotes supremacy of the races, this kind of violence research, that one race is better than the other. Then they were, what is the clinical utility? What is the utility of these types of studies? Are you going to take kids with a particular genetic profile and they're going to be put into a particular type of group? So they take an honor student. The kid's been doing great. And then you've got that violent gene, and we're going to start treating you for this gene problem when the problem is not there. And as one of the parents said, I think we've been duped to think that any of the results will be used to improve the African community because too much has been already used against us. So, one of the things I think we need to consider is, will research contribute to morally sound social policies? Funding of genomic research is often driven by economic and political concerns of the majority, and these may have little to do with or are antithetical to the concerns and social circumstances of the participant groups. Another thing that one of the African American parent groups said to me that was really hard to take was, Dr. Fisher, you're an agent of the government. Me? How am I an agent of government? I'm a researcher, academic freedom, I pose my own questions, but they made me realize that when I apply for a grant, I'm looking at what the announcement is. I'm clearly not going to write a grant proposal that's not going to be funded because it's not part of the overall majority position about what is important to do. They were also concerned that new geneticized diseases may be created for behaviors, and this would result in social inequities from the public, and that had the potential for genetic stereotyping, which in turn could lead to racially segregated interventions. And as we've seen in some sense in research, they're already racially segregated. Now, the IRB guidance and decisions to give researchers is not easy, because 46.111 actually tells IRBs that they can't consider the future use of knowledge from the research that may produce some kind of harm, and they give examples of its effect on public policy. So what's an IRB person to do? So here's just some suggestions of the questions that you could ask investigators to present in their applications to you. Are there scientifically valid reasons for research that is either explicitly or implicitly targeting racial, ethnic, minority youth behaviors? Are there implicit social political biases influencing the recruitment and inclusion criteria? Is the design sufficient to adequately assess the genetic versus not only environmental but larger systemic inequities that we see in terms of institutional racism? Do human subjects' protections that the PI is proposing reflect the values and merit the trust of participants? And for the most part, as you've been seeing in what I'm trying to present, ethical decision-making cannot be isolated from knowledge of how participants view the informational goods and harms of genomic research and other types of research. So, as I conclude, in the 1980s, Seymour Sarensen was addressing some of the ethical issues involved in socially sensitive research, and he asked the question, if it can be studied, should it? And so I want to leave you with a comment from a father in one of the African American focus groups, because I think he spoke to this much better than I can. The key is, Dr. Fisher, that when you talk to your counterparts, ask yourselves, what will others do with this research? No matter what role that you have played to make this happen, you could have the purest intention, but if it gets into the wrong hands, then it becomes a weapon. And I thank you. are we taking questions? I wasn't sure. I'm fine if we have time. Yes.
Yeah, I was curious about, like, the surveys that you did about adolescents, about reasons that they would want their parents to consent or not consent in your first study. Did you need to get IRB authorization to ask those questions?
Yes, of course, yes. This was a minimal risk study because it was a survey and focus group questions. We got permission to waive guardian permission for this type of information, and of course we got IRB permission. Yes.
Yeah, I just wondered if you could speak a little about whether that was a dilemma or not.
It wasn't a dilemma. I mean, I think social science research is also very helpful in determining the extent to which questions are or are not minimal risk. Okay, a lot of times IRB worry that you've just asked a kid about sex. If you ask them about drugs, they're going to start taking drugs. They're going to start having sex. I've done other studies supported by government funding that shows kids laugh at this kind of thing. Do you really think if you ask me a question about sex, that's going to make me have sex? Although I do think that we are responsible. If we're doing adolescent risk research, we should also make sure that we have statements about the risk, that we are not encouraging this, and especially with ethnic minority populations, that we don't assume that they engage in these risks. And so for all the studies that I do like this, we're running a study right now on transgender youth. And at the end of the study, we provide resources for them. We talk about, when we've done studies in the schools, we go in and give a presentation to all the youth when the study is over about high-risk behaviors. And so it's very important I've always felt it's so important to give back to participants because we're always taking from them. We're taking knowledge. It helps us with our publications. It helps us with our grants. But we have the knowledge to give back to them, and that should be part and parcel of dissemination.
Focusing on the LGBTQ youth, you may think that asking for recognition is either practical or a reasonable technical. I think the case you make for practicability is very strong. I'm still not entirely convinced, though, about the reasonable protection. You have a proportion of children who said that their parents would help them make the right choice.
Yes.
Sounds like a reasonable protection.
Yes. So the question, so remember that we're going to give those children the choice if they want to engage their parents in that. However, there's enough evidence out there that the kinds of fears that the youth had about being punished, stigmatized, kicked out of the house is a real-world concern. And so the question, that's what I was trying to argue, that if you're going to waive guardian permission, it's very important to give youth, number one, the option to get their guardian permission, and number two, to make sure that there are adequate substitute protections in place. And here you really have to balance what is the benefit of research that doesn't sample 50% or more of the youth who are most at risk for the type of prevention or intervention that you're studying. Okay, thank you very much. Okay, one more. So here I think you're really pointing to the issue of, does the disability itself make the child vulnerable to the research? And that's what you have to ask. I don't, you know, there are all different types of disabilities, but that's where goodness of fit comes in. If guardian permission is going to be waived, or even if it isn't, and you want appropriate assent procedures, you want to know what are the abilities of these individuals. Do they have some kind of vision handicap that Braille or audio informed consent would be the best way to approach them? So the point really here is that it's not the disability itself, but the extent to which that disability may impair consent, and what is the researcher's obligation to enhance that consentability during the process. Okay, thank you.